This conference will now be recorded.
Okay, thank you for coming to class this evening, folks. We are going to be finishing up the urinary system, and so we're looking at my notes at present. And so recall that we began an introduction into the urinary system and talking about the fact that the kidneys are taking a tremendous amount of blood and filtering it and producing a filtrate, which will eventually become urine. We see that the nephron is the functional unit of the kidney, and this is the structure that's actually taking the blood, filtering it, reabsorbing what the body needs, secreting what the body does not need. The secretion will end up going back into the tubular network, which will in turn then be enter into the renal pelvis, where the urine will collect and enter into the ureters, which will drain into the urinary bladder and leave the body via the urethra. Okay. So you see here the glomerulus. This is this knot of kidneys, this bowl of kidneys. It's covered in a glomerular capsule, right? And that this unit of the glomerulus, this knot of capillaries with the glomerular capsule, is called the renal corpuscle. Okay, so you should know that term also. Okay. And this is very important to just keep in mind that, again, it's filtration, reabsorption, secretion. Filtration, reabsorption, secretion, okay? The reabsorption, the actual, the blood vessels, the capillaries that are the peritubular capillaries that are covering the tubular network, right, of the nephrons and such, they are reabsorbing nutrients, reabsorbing water, reabsorbing ions and such, right? And secretion, we're putting into it wastes, and also water will be a part of that, a bit of water, that will end up becoming that filtrate, which entering into the collecting ducts will then drain into out of the pyramid of the kidney, the apex of the pyramid, via those renal papillae into the recall. And let's take a look here for a moment and just see here that we have, so let's take a look at this image here. So we see here that we have, here's the pyramids, there's the apex, the renal papillae draining into the minor calyx. The minor calyx, calyces, at the ends of, at the distal portions of each pyramid at the apex will drain into what we would call the major calyx, right? The major calyces will then drain into the renal pelvis, which will drain this urine into the ureters, right? And follow that into the urinary bladder, okay? I posted, this is a new image. I'm going to post this in documents and resources because I like this image because it also shows you the renal column. This is a term that I've not mentioned to you before, but I want you to know this term, the renal column. So there are columns between the pyramids. And so recall I said to you that the blood vessels that pass between each of the pyramids. So if a blood vessel, so let's find that image here. I want to find that image. Here we go. So these would be called interlobar, oh, sorry, interlobar arteries and veins, right? And why would they be called lobar, right? Well, here's the deal, is that you see right here, and that's in this, you see it's here, circulation in a single kidney lobe, because the kidney lobe concerns the columns as well as a pyramid. So the columns, half of a column on each side, as well as the pyramid, equal a lobe. So that's why these are interlobar, arcuate, artery and vein, cortical radiate, artery and vein. Now, they're also, aka also known as interlobular, these cortical radiate. But I'm okay with, and I tell you that cortical radiate is a proper term, and don't worry about the interlobular. Interlobar, that's a term. Interlobular, I'm not asking you to know, okay? But this is really important also as far as knowing this pathway right here, as far as blood entering into the kidneys. So you'll see here as far as the glomerulus, that knot of kidney, that knot of capillaries, and then what takes place as far as the drainage of that efferent of the glomerulus via the efferent arteriole. See, it's very unique in that arterioles are bringing blood to the capillary bed and draining the capillary bed. Okay? There's those peritubular capillaries that are going to be reabsorbing water as well as nutrients and such via reabsorption. okay? And then we're going to allow for then, go back and let's look at here. Oh, no, right here, this is better. And as you're looking at this image right here, you're seeing that we have these paratubular capillaries covering the tubular network of the nephron, okay? And as such, then we're going to put fluid and nutrients back into the cardiovascular system or reabsorb into the cardiovascular system or secrete back into the tubular network. So then what happens, folks, is that in this tubular network, we have, so here you'll see glomerulus, right? You'll see the afferent and efferent arterioles, right? And you'll see here that this is the proximal convoluted tubule. Here we have the nephron loop, distal convoluted tubule draining into the collecting duct, okay? And so within the tubular network will be filtrate, and once we get to the collecting duct, it's going to become urine and will leave via the renal papillary into the minor calyx of the renal pelvis. Okay, go back to our notes here. So you'll see here that, again, filtration, reabsorption, secretion, really important for you to get an understanding of what's taking place. Reabsorbing into the blood, secreting back into the tubular network of the nephron, right? That will become the filtrate, which will eventually become urine, okay? Know that proteins in blood cells normally too large. If there's damage, if there's some type of disease process going on of the kidneys, and particularly affecting the nephron, then we will have proteins and blood. We will have proteinuria. We will have hematuria. And this is a pathology, and this is a sign of that there's disease taking place. There is some type of pathology, some type of destruction taking place of the nephrons present within the kidneys. We talked about and we reviewed before regarding the color of urine, right? A pale straw type color, slightly acidic, right? 6 is a pH of below 7. 7 is neutral. Below 7 would be acidic. We talked about it's sterile, so there should not be any bacteria present. If there is, then that means that there's some type of infection going on, right? Could be a UTI, could also be a kidney infection, right? So we don't really want to see any bacteria present within the urine. The act of voiding, of urinating, would be also called voiding micturition, right? Emptying of the bladder. We talked about as far as pH is concerned, whether it rises or it falls. So know that we have the homeostatic balance is maintained as a result of negative feedback. It's what takes place. Always bringing back to where it should be as far as a set point. And pH is one value that would be monitored and making sure that we're approximate 6. Okay? These hormones here, aldosterone and antidiuretic hormone, okay? So these are very important to realize that these have a very strong influence on what takes place as far as volume of fluid is concerned. And in particular, if there is and we talked about this, fluid volume within the body, if we increase fluid volume, then we'll increase blood volume. And if we increase blood volume, we increase blood pressure. So if blood volume goes up, blood pressure goes up. Blood volume goes down, blood pressure goes down. And hence we give diuretics to patients in addition to their other blood pressure medications in order to increase urine output to decrease blood volume, to decrease blood pressure, okay? You'll see here I've highlighted as far as aldosterone in particular, very important as far as increasing reabsorption of sodium, and where sodium goes, water also follows, okay? So increasing sodium reabsorption, which will then have water follow, so then we're going to increase more water reabsorption, which will in turn increase blood volume, increase blood pressure. ADH is a water conserving hormone, so we're going to produce less urine, which will in turn lead to an increase in blood volume, increase in blood pressure. And you'll see here also, this is ADH, antidiuretic hormone, primarily responsible for maintaining the concentration of sodium, although you would think it would be aldosterone, It's really ADH has more of a stronger effect. Okay. ANP. So you're going to see that most of these hormones will actually increase blood pressure, but atrial natriuretic peptide actually is involved in lowering blood pressure. But again, when there's a issue where a patient has chronic high blood pressure, ANP is not going to work to decrease blood pressure. Okay? You'll see here, as far as alcohol is a diuretic. So it inhibits the release of ADH. So alcohol inhibits ADH. Hence, what do? You increase if you're drinking alcohol and you drink a lot of alcohol, absolutely, you're going to increase more urine production. So that's why alcohol is a diuretic. It is inhibiting the release of antidiuretic hormone, which is a water conserver. Okay? So the condition. So I said to you that these hormones are involved in having the ability to increase blood pressure. Now, the condition of decreased blood pressure and blood volume. So short term, let's look at that first. So short term, we get it. Epinephrine, norepinephrine, these are involved in sympathetic stimulation, and this will absolutely jack you up, right? It'll increase cardiac output. It'll increase peripheral vasoconstriction, which will lead to more blood going to skeletal muscles, and as a result, you're ready to fight or flight, excuse me, or run. It's going to increase your blood pressure. You're ready for action. That's a short-term increasing of blood pressure and volume as far as condition is concerned. Condition here is decrease, so we want to increase that. Well, epinephrine, norepinephrine can do that. Long-term, this is what's taking place, okay? Long-term, so nervous system control would be short-term increased blood pressure. Short-term, long-term would be the urinary system, okay? And in particular, using hormones to do this. You'll see here as far as renin was released by the kidneys, which will in turn activate angiotensin 1 present in the lungs, which will be converted to angiotensin 2 by ACE, angiotensin converting enzyme, right? And this will in turn lead to this response of vasoconstriction, ADH release. So we're going to, if ADH is released, we're going to conserve water. Aldosterone is secreted, so we're going to do what? We're going to reabsorb more sodium ions. Water follows sodium, so we're going to increase blood volume, right? Increase blood volume. Thirst is stimulated, also increasing blood volume. So as a result of increasing the volume, we're going to also increase blood pressure, okay? So you'll see here, these all lead to an EPO also, right? Released if blood pressure is low or oxygen content is low, because what's going to happen? EPO stimulates blood cell production, red blood cell production by the red bone marrow. Now you're going to see that in just a moment here. So we can either have blood pressure medication to reduce blood pressure by affecting ACE, angiotensin converting enzyme. So we can have an ACE inhibitor, okay? We can have an ACE inhibitor, or we can have an angiotensin receptor blocker, okay? Angiotensin receptor blocker. So if you block the receptors for angiotensin, then you're also going to stop this whole process that can lead to an increase in blood pressure, increase in blood volume, therefore increasing blood pressure. Okay. So here, as far as diseases are concerned with the kidneys, so it's attacking the nephrons, and that's a key issue there. Again, filtration, reabsorption, secretion. Remember those, that's what the nephron is doing, right? In order to produce a concentrated urine, right? Diabetes, high blood pressure, these are all can affect the function of the nephrons and lead to destruction of the nephrons, in particular high blood pressure. Imagine that little bowl of capillaries, right? That glomerulus, by high blood pressure, can damage those small vessels, which can lead to then larger cells leaking into urine, right? So you'll see here, as far as proteinuria, hematuria, red here. I mentioned this to you before, as far as blood pressure medication, the ACE inhibitors and the ARBs, the angiotensin 2 receptor blocker, right? All blocking that mechanism, that long-term mechanism of increasing blood pressure. Okay? Polycystic disease is quite a devastating disease, and patients can live with this for a long period of time, but over time, the kidneys end up being, the kidney tissue becomes replaced with these cysts, and these cysts then are not involved in filtering the blood, forming the urine, so they really, they take the place of the areas where the pyramids and the nephrons should be. Right? So here, folks, you'll see here as far as that the kidney size can double in size, folks. And you'll see here that these cysts, again, then they are blocking the areas and replacing the tissue of the pyramids and so the pyramids are in the medullary region, the cortical region, right? This is where we have our nephrons are present. Let's take a look for a moment. Actually, let's pull up this image. Yeah, I'd like to just go over this one again with you and review this as far as, so you'll see that we have here these cortical nephrons and these juxtamedullary nephrons. Primarily, there's cortical nephrons that are present. And so primarily so you'll see the cortex, here's the cortex, here's the capsule, that thin line there, the capsule of the kidney. In the cortex, most of the tubular network, as well as the glomerulus and, well, the renal corpuscle containing the glomerulus and the glomerular capsule, you'll see here that primarily the nephron is present within the cortex, hence the term cortical nephron. The juxtamedullary has still a lot of the apparatus, right, in the cortex, but the nephron loop, right? So we have here, if you're looking at here, yeah, here we go, descending and then ascending loop is primarily present within the medulla. Okay? And you'll see here that we have these collecting ducts, which will take the urine and drain it out of these renal papillae into the minor calyx. So very, very important that these nephrons have the ability to do their functions. Let's see here, good. All right, so you'll see here that it's a progressive disorder, okay? Progressive disorder, and what can happen is that they can receive a kidney transplant, right? Now, I would tell you that depending, I know some, eventually, yes, yeah, Megan. Thank you for sharing that, Megan. Yeah, it's sad stuff. So, you know, they can receive transplants. Know that because this is a disease that's present within their body, that eventually that can also affect the transplanted kidney. We have a relative who has a kidney transplant who is now on dialysis and in need of another kidney to replace the one that he had received going on close to 15 years ago. And the reason why he was able to have his kidney for so long was that he received a kidney from his father. So they're able to last much longer than just a receiving kidney from someone who's not related, but still a match. Now, this is something I need to make mention of to you because you're all going to be working with patients and understanding that patients will come. So I, as a chiropractor, dealt with many patients who were in some type of pain. And, you know, yes, absolutely, there are acute episodes of chronic pain or just acute episodes of pain, but many patients were in chronic pain. And so they would have, you know, periods of bad times and then, you know, lower pain and better times. But know that people will overuse over-the-counter pain medications and think that it's not really going to be a problem for them. Approximately 10% of new cases of chronic kidney failure caused by an overuse of painkillers. And we're talking about analgesics that are, you know, Tylenol and ibuprofen and such. And I've had patients come into the office and tell me crazy numbers of how many they're taking at one time. And you're just like, holy cow, yikes. Don't be your own doctor, please. But, you know, people, you know, can be compliant, but many people are non-compliant regarding pain. Because, you know, if you've ever been any type of pain long-term for a couple of days to a couple of weeks, no one wants to be in pain and it's terrible, but, you know, there has to be better ways than just managing it with just painkillers, analgesic. Renal calculi. So these are when patients have, here we go. this image right here, so we're looking at these calculi present within the major calyx, present within, because you'll see here, minor, minor, major, right? Minor calyx here, major calyx, renal pelvis. And so these stones can block this network here that we have where we're draining urine into the pelvic area. And I've seen patients, as far as images from patients that have had staghorn calculi, where they've had stones present throughout the whole pelvis, so that we're not even draining much urine into the ureter. It's just terrible. And look that up if you have a chance. Staghorn. Actually, I'll look that for you right now. Yeah. So look at that there. Yeah. So here, this is just. I mean, folks, that's present within the whole pelvic area, going into the ureter. Look at that, right? How is that kidney functioning? How look at this image here. All these stones present and such. That's devastating. Look at this image here. Wow, that's remarkable. So stones, kidney stones, renal calculi can be devastating. You can see that we can have them block, and so they can block the area of the in the pelvis and the ureter, end up into the urinary bladder. Oh, Sam, I'm sorry for him. I have never. My brother has experienced kidney stones. I have not, but I've had many patients over the years. I've had patients over the years who come in and they believe that they have back pain, and they do have back pain, but they think that it's a low back etiology, right? Something going on with the low back, and really the etiology is that they're experiencing kidney stones, and that's kind of a hard thing to deal, and you have to do a differential diagnosis and determine what's going on and what's taking place. Oh, 7 millimeters, yikes. Boy, oh boy, that's horrible. I know that it's important to hydrate. And many times when patients are experiencing the kidney stones, it's primarily, it's increased during summertime because people aren't hydrating enough. And that can lead to an exacerbation of issues with kidney stones. Tough stuff. Yeah, so you see develop in the pelvis, the calyces, right? Dehydration, a predisposing factor, like I said before too there. And dialysis. So I mentioned to you this dialysis. So we have a relative right now who is on 6 days a week, 6 times a week, doing hemodialysis. And so what's going on is that there's an exchange that takes place within the abdominal pelvic region. And so there's a port present so that I forget the name of the dialysate, I think it's called, actually will then enter into the abdominal pelvic region, and then you'll wait overnight, and then see, I pointed to the wrong thing. Peritoneal dialysis. Sorry, this is where it's at night, and where they're actually having this exchange taking place, and in the morning you drain what's taking place within the abdominal pelvic region. I apologize, folks. Hemodialysis. This is where we're actually having they've created either a graft or a fistula. Okay, and you'll see here where then they have access to this fistula, which is an AV fistula, right? This is an area where we have an artery and vein connected, and so that you'll see here connecting to the vein itself, but connected directly to the artery. And you'll have blood from the dialysis, you'll have blood removed, filtered, and then returned back to the artery, vein. Okay. Optimal blood flow made by connecting an artery to a vein. Best choice for the hemodialysis, which would be at a clinic, hospital, clinic. That's where the hemodialysis takes place, 3 to 6 times per week. Many patients, the patients that I've taken care of over the years that have been on dialysis, we're doing hemodialysis, and 3 times per week is usually the schedule. And here's that's the hemodialysis, right? And so whether there's a graft or a fistula, that's what's taking place there. Here in the peritoneal dialysis, there is this infusion. So it's saying here, yeah, I think it is dialysate. And there's the infusion taking place. And family members do this for the patient. Family members do this for the patient. The abdominal pelvic cavity is filled with the dialysate, and then it's drained in the morning. You'll see here, as far as where it says the body will fill with fluids, edema. Um, this is not a good thing as far as end-stage renal disease. We need to have, if a kidney is not functioning, the patient needs to be on dialysis or they will die. Okay, this is very bad. So the blood needs to be filtered. And so know that either you're doing the hemodialysis or the peritoneal dialysis, but realize that your kidneys are functioning 24/7, right? Whereas here we're doing about 3 to 4 hours for hemodialysis, 6 to 8 hours for peritoneal dialysis, and here we're doing it every night. Here we're doing it 3 to 6 times per week, but it's still not 24/7 like our kidneys do as far as removal of waste products and such. And you'll see here, as far as giving you some more information regarding this. So the sphincters that are present, just as in the digestive system, the internal will be involuntary, the external will be voluntary. So this way we can control when we void, and as in the digestive system, when we defecate. Okay? And you'll see this, and I'm going to go over this again with you in the reproductive system and looking at reproductive anatomy, but realizing that, so the female urethra, 3 to 4 centimeters. We're looking at, as far as prostatic, membranous, and spongy urethra. We'll look at that image when we get into the reproductive system. Okay. And you'll see here that simultaneous events occur. So recall that when I talked about parasympathetic division influence, remember we use that acronym SLUDD. So salivation, production of saliva; lacrimation, production of tears; urination, production of urine; all right, digestion, defecation. So you'll see here a contraction of detrusor muscle by the autonomic nervous system, opening, in particular the parasympathetic branch, opening of the internal urethral sphincter, again parasympathetic in the autonomic nervous system, and opening of the external. This is somatic, because this would be something that you have conscious control over. So that's skeletal muscle, right? So that's skeletal muscle control, somatic nervous system. Now you'll see here, as far as for infants and such, and then as far as for children. So this was one of the most challenging things. I think I might have said this before, but having the ability to be able to quote unquote potty train your children can be very challenging and not an easy thing at all. But to get them to learn that they can control when they void is a big deal. Okay, so you'll see here, as far as you can review that. And then I've just given you just a little bit more, just this at the end of the note here regarding seeing here, as far as just showing you what's taking place, as far as what's leaving, as far as, so this would be reabsorption, these arrows going out of the tubular network, right? This is, so look at this here. So this would be the renal corpuscle, glomerulus, glomerular capsule, proximal convoluted tubule, PCT. Then this would be the descending branch of the nephron loop, the ascending branch of the nephron loop, and then the distal convoluted tubule. It's not convoluted here, they're just, for example, and then draining into the what? The collecting duct, right? And this will be the concentrated urine leaving the body, draining into the minor calyx. And you're seeing here, so again, any arrow that's exiting, that's leaving from the tubular network, would be reabsorption. Any arrow that's entering into the tubular network would be secretion, right? Secretion, so that we're actually taking back into the urine. So you'll see here, as far as product of protein metabolism entering back into the urine. Okay. I'm not going to really hard time you regarding what's taking place where, but knowing that a good deal of reabsorption is taking place at the proximal convoluted tubule, primarily. Reabsorption is taking place at the proximal convoluted tubule, and then water reabsorption primarily taking place in the descending loop and also in the collecting duct. Okay. Here's just another image, just showing you exactly what's taking place and what's going on regarding the filtrate and what's entering, what's being reabsorbed, and what's being secreted. That's helpful to you all.